is the clinical diagnosis. So ours is neonatal meningitis or neonatal septicemia. Is there evidence of significant bacterial infection? Yes, there is significant bacterial infection. The patient definitely needed antibiotic treatment. So what are the commonest agent causing neonatal septicemia, neonatal meningitis? So in a normal delivery, so the flora in the normal flora of the vaginal tract could be the pathogen causing neonatal septicemia or neonatal meningitis. So these are the common 4 bacterial agents: Escherichia coli, Klebsiella pneumoniae, Streptococcus agaricus, that is group B, Streptococcus, then your gram-positive bacilli, that is Listeria monocytogen. So what our state guidelines says, you go with the first line drug with the meropenem, then followed by alternatively we can go with the cefotaxime or gentamicin. We look at our National ICMR guidelines 2024, what it says to the resistant pattern for E. coli in urinary tract, OB patients. So OB patients, third generation cephalosporin is only 29% is sensitive. That means a community acquired urinary tract infections, you can see third generation cephalosporin were only 30% were susceptible. So 70% were ESBL in a community acquired UTI. This is our national ICMR AMR 2024 report. So we look at the each antibiotic guidelines, so antibiotic scenario. So if we use cefotaxime and gentamicin, so our state, our national average almost 70 to 80% were ESBL. So ESBL, cefotaxime won't cover, but if you gentamicin may cover E. coli and Klebsiella. But the problem with the gentamicin is less penetrating to the CSF. Group B streptococcus, yes, cefotaxime will cover very good, but gentamicin no need. Listeria monocytogens, both cefotaxime as well as gentamicin may cover, but cefotaxime, all Listeria monocytogens were intrinsically resistant to all cephalosporin. So if I use cefotaxime and gentamicin, I won't cover all these 4 pathogens. If I use vancomycin and cefotaxime, again I will not cover against E. coli, Klebsiella, I will not cover against Listeria, but I may cover group B streptococcus only. Then if I add ampicillin, vancomycin along with the cefotaxime, I may cover Listeria, I may cover group B streptococcus, but I may not cover E. coli and Klebsiella. I don't know what is the causative agent among the 4. If I use ampicillin, vancomycin, cefotaxime or cefotaxime, gentamicin or cefotaxime, vancomycin, I may miss any one of the organism. So whatever state guidelines shows, so meropenem, ESBL, Klebsiella, ESBL, E. coli, it will cover. Group B streptococcus will be covered with meropenem. Listeria monocytogens, the first drug of choice is ampicillin and gentamicin, and second drug will be IV combination of drug of choice in CNS infection. So meropenem is the good drug of choice, even though some resistant seen or therapeutic failure seen with meropenem for Listeria monocytogens. So if I use meropenem in a neonatal meningitis, that is the drug of choice. So in our case, meropenem is the drug of choice. Before starting any antibiotic, we need to know what are the drug will not be effective in the respective infection sites. So this is in our national guideline. So CNS infection, so drug that not able to penetrate the CSF or agents administered orally. So no drug if administered orally will not be effective. Then your first and second generation cephalosporins, no penetrating power. Then your carbapenem like doripenem and ertapenem. Why doripenem and ertapenem? No penetrating power, larger molecule. Imipenem have very good penetrating power, but is not a good drug of choice in treating meningitis because high convulsion potential. So all the 3 carbapenem were not effective in treating CNS infection. Only meropenem is the drug of choice. Then your macrolides, tetracycline as well as your clindamycin, no penetrating power. Fluoroquinolones all have less penetrating power except your moxifloxacin. Then your BL-BLA combinations like Piptas, amoxiclav, sulfasalazine, sulfactam have very less penetrating CSF power. So these agents should not be used to treat meningitis infections. Then in a respiratory infection, that also not a good drug of choice. So always for any respiratory infection, if you use colistin, polymyxin B, tetracycline, you have to use some come with these three drugs. Then infection other than UTA, that is apart from UTA, aminotracheosis monotherapy should be avoided. So other infections other than UTA, aminotracheosis should be combined with some other drugs. Then upper UTA, nitrofurantoin and oral fosfomycin, less penetrating power to the kidney, not needed. Then UTA, macrolide, tetracycline, polymyxin B. Colistin may be used, but polymyxin should not be used. Very good renal excretion, but liposomal amlodipine very poor renal excretion. So these drugs should not be used to treat urinary tract infection. But we are in case of renal failure, these are the drugs to treat other type of infections. Because no renal excretion, we can give in a full dose. Macrolide, tetracycline, polymyxin B. I forget to what. Lidisolid also less renal excretion. Lidisolid should not be used. Then ocular infection, echinocandin will not be effective. So back to our case, we started therapy now 120 mg per kg per day in 3 gram-positive cocktail in clusters. Group B streptococcus gram-positive cocktail in pairs. P code is the gram-negative base. Also cap positive and Y split positive. So drug of choice for Listeria monocyte agents. So ampicillin gentamicin is the first line agent. Second line IV cotrimoxazole or intrathecal cotrimoxazole, meropenem. Maybe some failure rate with meropenem. And then piptas is not a good drug, cephalosporin. So this is what Mandel says. So ampicillin gentamicin, then cotrimoxazole, piptas as well as meropenem are the alternative agent. So our patient need to be de-escalated from meropenem to ampicillin and gentamicin. So which other bacterial agent where penicillin or ampicillin susceptible, but all cephalosporin were intrinsically resistant. Apart from Listeria monocyte agent, what is the other bacteria which is penicillin, ampicillin sensitive and all cephalosporin resistant? So our Enterococcus species, the ampicillin sensitive, cephalosporin were intrinsically resistant. Then if this is the culture CSF culture report from the 5-year-old male boy, you can look at the culture report. Streptococcus pneumoniae grown in the culture, penicillin resistant, ceftriaxone resistant. So we are dealing here case of penicillin resistant, 10th generation cephalosporin resistant, Streptococcus pneumoniae. How will you going to treat? So what Harrison says, if the isolate that is Streptococcus pneumoniae is penicillin susceptible, either we can use 10th generation cephalosporin or penicillin is the drug of choice. We have to discontinue. Vancomycin is empirically started. If the isolate penicillin resistant and cephalosporin susceptible, we can continue with the cefotaxime and ceftriaxone. We have to discontinue vancomycin as an empirical therapy. If the isolate, we have to continue vancomycin along with one of the 10th generation cephalosporin drug. Why? In Streptococcus pneumoniae infection, vancomycin has to be added along with any one 3rd generation cephalosporin. Can check with the Mandel, check at Streptococcus pneumoniae with ceftriaxone resistant, vancomycin plus ceftriaxone or cefotaxime. But look at the staph aureus. If it is MRSA, that is methicillin resistant, vancomycin is only the drug of choice. If you look at the Harrison, almost the same. Streptococcus pneumoniae, penicillin resistant, cephalosporin plus vancomycin, but staph aureus only vancomycin. Why we have to add vancomycin along with the 3rd generation cephalosporin? Because the vancomycin usually act on penicillin binding protein 2A. What is the resistant pattern in Streptococcus pneumoniae? It is 2X along with the 1A. So high level penicillin along with the 3rd generation cephalosporin resistant. That's why we need to add 3rd generation cephalosporin along with the vancomycin to treat Streptococcal pneumoniae meningitis. Some other case, 14-year-old meningitis, CSF meningitis features showing lymphocytic pleocytosis, mildly elevated and normal sugar. All the culture, blood cultures were found to be negative. Then biofire, you can check almost 14 to 18 organism, bacteria as well as viral organism as well as cryptococcus. All biofire were negative, but the patient is improved with acitral or doxycycline. So what could be the differential diagnosis? Is there it could be a bacterial agent? Yes, it's the Scrub typhus. So scrub typhus can mimic as a gastrointestinal infection, respiratory infection, as well as CNS mimic the meningitis infection. So patient is improved with acifral or doxycycline. These are the usually routine features: lymphocytic phagocytosis, mildly or elevated protein, normal sugar. Cultures were negative and biofilm will be negative. Then move on to the second case. So 5-year-old female, complaints of sore throat, exudative pharyngitis, fever plus, there is cervical nodes. Patient having mild cough. Patient also not allergic to the penicillin. Should we start antibiotic to the patient? 5-year-old, exudative pharyngitis, fever, cervical lymphadenopathy, moderate cough is present. Do we need to start antibiotic, or do we need to start amoxicillin, azithromycin, cephalexin? So this is a clinical diagnosis, acute pharyngitis. So whether we need to start antibiotic, we will look at the what guidelines says. So these are the inappropriate use of antibiotics. So what are the inappropriate use? If antibiotic use unnecessarily, that is inappropriate one. Improper antibiotic selection. In CNS infection, already said, if you choose cefuroxime for treatment, only first and second generation cyclosporine, less penetrating power. Or if you choose imipenem for treating CNS infection, less penetrating power, good penetrating power but high convulsive potential. So improper antibiotic selection. If you choose doxycycline to treat urinary tract infection, improper antibiotic selection. Then errors in antibiotic dosing. So cefatoxime should be given in a full dose, 2 gram, at least 8 hourly. We have to give 1 gram BD is not the dosage. Error in antibiotic duration. At least for meningitis, Streptococcus pneumoniae, we need to give 2 weeks duration. So these are all the complaints called as inappropriate antibiotic use. So what our guidelines is for pharyngitis, go with the CENTAS course. So what CENTAS course says, if there is exudative pharyngitis, if there is tender cervical lymphadenopathy, if there is fever, but absence of cough. So each carry 1 mark. So if the score is more than 3 and 4, there is bacterial infection, we need to treat with antibiotic. If it is less than 2 or equal to 2, and bacterial infection is unlikely. So whatever case, exudative pharyngitis plus tender cervical lymphadenopathy are also there, fever also there, but our case is cough is present. So only the CENTAS scores of our patient is 3. So bacterial infection is likely, we need to go with the antibiotic. So what our state guidelines says, so first line penicillin is widely not available now. So we go with the amoxicillin is the drug of choice to treat Streptococcus pharyngitis. So unnecessary antibiotic use. So what are all the conditions? Antibiotic should be used always. What are all the conditions? Antibiotics should not be used always. What are the conditions? Antibiotics may you have to use sometimes. So in pneumonia, almost 100% we have to use antibiotic. In urinary tract infections, we have to use antibiotic 100%. In case of chlamydia or gonorrhea or pertussis, we have to use antibiotic 100%. Then like upper respiratory infections, then bronchitis, influenza, non-suppurative otitis media, asthma and allergy, antibiotics are not always needed. These are the additional information available from our national ICMR guidelines. So acute laryngitis, bronchitis, pancreatitis without infection, that is mainly alcoholic pancreatitis, PO without sepsis, acute pharyngitis less than 2 CENTAS score, acute diarrhea without danger sign. These are all the additional no antibiotic guidance from our national ICMR guidelines. In some other conditions, the culture may come as a positive one, but we no need to start antibiotic. So what are the conditions? Antibiotic not needed, even the culture was positive. So asymptomatic bacteria. So asymptomatic bacteria only for pregnancy. In urogenital infections, these 2 criteria, before any urological procedure, all other asymptomatic bacteria. What is asymptomatic bacteria? No symptom, but culture positive for 10 to the power of 5 organism. Apart from pregnancy and urological procedures, no need to start treatment for asymptomatic bacteria. If throats of growth, E. coli, Klebsiella, Pseudomonas, so Streptococcus pyogenes as Corynebacterium diphtheria or Argonobacterium hemolytica, sometimes Neisseria gonorrhea are the four pathogens are causing pharyngitis. So throats of only these four agents were diagnosed as a pathogen. Vaginal swab, so E. coli, Klebsiella. So what is the common pathogen? You can detect from vaginal swab. So all anaerobic infections like your Gardnerella vaginalis, obilungus can be a pathogen. So all other bacteria could be a commensal only. So surface wound swab. So if you swab the pus from the surface, that's also mislead for treatment. So surface wound swab also should be you can avoid antibiotic for that patient. So in what are the other conditions, antibiotic may sometimes needed. Like for acute pharyngitis, less than 2 not needed, more than 2 needed. Acute otitis media not improved with the symptomatic treatment, we have to go with the antibiotic. If the otitis media more than 2 weeks of duration, sinusitis again symptomatic treatment is okay. Then not resolved more than a week or 10 days, we have to go for antibiotic treatment. So antibiotics sometimes needed for some conditions. Then move on to the that case, a 10-year-old male admitted for some other reason. So central line was inserted. You can see some gradual onset of localized pain with redness, swelling, warmth after time. So central line insertion. After some days, patient developed warmth and swelling of the thigh. Fever with the signs of systemic infection. So what it could be a case of acute hematogenous osteomyelitis. Acute hematogenous osteomyelitis. So we need to give antibiotics. So what is the best investigation to detect osteomyelitis? So this is the MRI is the best investigation. So X-ray, ultrasound, bone scan, compare with the MRI, very less sensitivity. MRI along with your microbiology culture report, then your CBC could be a target factor for diagnosing osteomyelitis. So what should I start for this patient? Shall I start with amoxicillin or fluxacillin, cefatoxime or peptas? So before starting antibiotic, I need to know, so what is the pathogen causing osteomyelitis in acute hematogenous? So we look at our state guidelines, what it says. If it is acute hematogenous osteomyelitis, so Staphylococcus aureus is the commonest agent. If it is open fracture osteomyelitis, gram-negative bacteria is the commonest agent. So if open fracture, I need to target gram-negative bacteria. This is our case is acute hematogenous osteomyelitis. I need to target Staphylococcus aureus. So what our state guidance is, so if it is MSSA, cloxacillin, flucloxacillin or cefazolin, so we need to go with cloxacillin 2 gram, cloxacillin, IV cloxacillin 2 gram, 6th hourly is the dose to treat osteomyelitis. Oral cloxacillin has very less bone penetrating power. So orally you should avoid cloxacillin as a treatment to treat osteomyelitis infection. So IV cloxacillin, higher dose for the kilogram of body weight should be given 6th hourly, minimum 6th hourly. This is a prosthetic joint infection, 58-year-old male, operated 18 months previously. Now during the wound wash, the swab was taken from the pus sample. The pus fluorochrome, Dr. Jeyamani, that is sensitive to D.G.Sivakumar as well as amikacin and cholesterol. Then Enterococcus faecium, that is sensitive to vancomycin and penicillin. So high level resistant to organisms, Acinetobacter, carbapenem resistant, Enterococcus faecium, vancomycin susceptible and penicillin susceptible only. This is a culture from the operative swab while doing the wound wash. Patient already empirically started on cefazolin. What should we do now? Shall we start the vancomycin or doxycycline or Acinetobacter is a common solve? We start only either vancomycin or penicillin to cover Enterococcus faecium, or treat only Acinetobacter, Enterococcus. What should we do? We look at our journals and our state guidelines. So what it says for prosthetic joint infection diagnosis, at least 3 or more specimen where the culture sample grew the same organism should be the pathogen of the prosthetic joint infection. 3 or more specimen, the same organism should be grown. What our state guidelines is, so at least 3, optimally 5 to 6 sample. Tissue sample is the better sample. So sterile container, at least 5 sterile container, 5 tissue sample taken separately put in the sterile container, that sent to the microbiology lab for culture. At least 3 samples should grow the same organism considered as a pathogen. So after taking 5 samples, Dr.Padmanaban grew in none of the specimen. Enterococcus species grew in 4 specimen. Cons grew in 1 specimen. So which is our pathogen? Enterococcus species. So the patient was started on vancomycin, and after 2 weeks, patient shifted to linezolid orally. So linezolid has very good bone penetrating power. So always surface swab should be avoided. Wound swab always should be avoided. If there is pus, wash the wound with the saline. Then with the base of the wound that has been fused, the serum sample should be taken and sent to the culture, not the protein pus from the surface or any serous discharge from the wound. Discharge outside the wound, that also should not be swabbed. Only at the base, cleaned with normal saline, the base should be squeezed, that should be sent for the culture. If you want to diagnose a prosthetic joint infection, at least minimum 5 tissue samples should be sent to the microbiologist for confirmation of pathogen. Then move on to the next case. 50-year-old male, fever with the cough expectoration, progressive difficulty in breathing, diabetes mellitus, and smoker for 30 years. So 50-year-old with some comorbidity. So what agent choice? Either amoxiclav or amoxiclav with doxycycline or azithromycin, or cefatoxin with doxycycline or azithromycin, or piptas. So which one I have to choose? So always follow guidelines. So this is the community acquired pneumonia, definitely antibiotic needed 100%. So whatever guidance is, go for with the Karbu score. There are some additional scoring system also available in our textbook. So we are following Karbu score, that is Karbu 65. So what is C? That is confusion. Urea, that is blood urea nitrogen. From urea, how will you calculate the blood urea nitrogen? Urea divided by 2.14, that will give you blood urea nitrogen. Then respiratory rate, if it is more than or equal to 30, systolic BB less than 90, diastolic BB less than 60, and age is more than 65 or 60 years old. So look at what our case. So confused, score 1. Respiratory is not more than 30, no score. BB 120/90, no score. Then blood urea nitrogen only 9.3, not more than 10. So only age is only 50. So our Karbu score is 1. But our patient has some comorbidity with diabetes as well as smoker for almost 30 years. So this is our state guideline says. So if the Karbu score is 1 or less than 1, we can treat as a OB patient. OB patient without comorbidity, some type of treatment, empirical treatment. OB patient with comorbidity, we have to go with amoxiclav, macrolide, or doxycycline. Either azithromycin or clarithromycin, or with doxycycline, we have to go. So this is the inpatient. If the Karbu score is 2, non-ICU. If the inpatient Karbu score is more than 3, ICU. If additional risk factor for pseudomonas infection, we have to go with Karbu score 3 for covering pseudomonas agent. So our patient Karbu score 1, comorbidity. So we have to start with the amoxiclav with azithromycin or doxycycline. 2 different group of agent, amoxiclav or either with azithromycin or doxycycline. 2 different group of agent for a Karbu score of 1 are the promoting antimicrobial resistant. So these are the common agents causing community acquired pneumonia, Streptococcus pneumoniae, H. influenza, then Moraxella catarrhalis, Chlamydia pneumoniae, and Mycoplasma pneumoniae. Right. If I use amoxiclav will only cover Streptococcus pneumoniae. So Streptococcus pneumoniae, no penicillinase producing. So amoxiclav, both are same for Streptococcus pneumoniae. but H. influenza, monoxide catarrhalis, both producing beta-lactamase enzyme. So amoxicillin only will cover these two. So we put amoxicillin to cover all the three, but amoxicillin is not a drug of choice to treat Lambda-Fluor pneumonia as well as Mycoplasma pneumonia infection. But look at the doxy or azithromycin that will very quickly cover Lambda-Fluor pneumonia and Mycoplasma, but their resistant pattern may increasing with the Streptococcus pneumoniae, H. influenza and Moraxella catarrhalis. So if you combine both these two drugs, amoxicillin with either doxy or azithro, that will all cover your agents causing community-acquired pneumonia. After culture, we may de-escalate or escalate to a particular antibiotic. So we move on to the next case, 43-year-old male, chronic smoker. So there is a comorbidity, 6 days cough, greenish sputum, 1 day right-sided chest pain, mild dyspnea, BP, temperature, pulse rate almost were normal. So chronic smoker, 1 day, 6 days cough, green sputum, 1 day right-sided chest pain. No chest X-ray as per abnormality, mild total count increase. So shall we start levofloxacin as the sputum is green color, as the flu season, shall we start with amoxicillin along with either doxycycline or with oseltamivir? As the patient is having dyspnea as well as mild chest pain, shall we need to go for IV antibiotic or no antibiotic? So what's our case? It's a case of acute bronchitis. So what our guideline says, acute bronchitis, no antibiotics. Even there is sputum is purulent, no need for antibiotics. So why no antibiotic? Because it has no impact on the severity of the cough. It has no impact on the duration of the cough. It does not prevent any complications like pneumonia or bronchiolitis. So antibiotic is not warranted in acute bronchitis. So move on to the next case. 23-year-old male, 7 days fever, able to take orally, water tongue, mild splenomegaly, blood culture grew, salmonella typhi. So salmonella typhi infection. So these are the how to proceed. Ceftriaxone 1 gram, cefixime 400 milligram, cefixime 200 milligram, ciprofloxacin. The patient already able to take orally, which could be the drug of choice. We will look at the guidelines. So whatever guidelines says. So initially go with the cotrimoxazole or azithromycin. If you want to go parenteral, go with the ceftriaxone 2 gram IV OD. Alternatively, cefixime, chloramphenicol, amoxicillin can be used. So what Harrison says, if the organism, if the culture positive, if it is fluoroquinolone susceptible, we can go with the ceftriaxone, azithromycin. We can go. If you look at the ceftriaxone, they put some score A. What it denotes? Cefixime 400 milligram. So if the organism is fluoroquinolone susceptible, we have to go with the cefixime 400 milligram. That is the highest dose we have to go, not 200 milligram BD. You can look at both in the susceptible as well as the resistant, fluoroquinolone resistant. Azithromycin dose is 1 gram OD for 5 days. Even also for fluoroquinolone resistant azithromycin, 1 gram OD for 5 days, not 1 gram statum followed by 500 gram OD for another 4 days. So all 5 days we need to give higher dose of azithromycin. If it is fluoroquinolone resistant, ceftriaxone 2 gram. So in India, almost as per ICMR guidelines, more than 90% were fluoroquinolone resistant only. So we need to go with the, these are the underdose. Ceftriaxone 1 gram, underdose. Cefixime 200 milligram, underdose. Either 400 milligram if fluoroquinolone susceptible. If it is fluoroquinolone resistant, we have to go with the ceftriaxone 2 gram. So as per Indian scenario, we need to go with the ceftriaxone 2 gram OD for at least minimum 5 to 7 days according to the patient improvement. Then move on to the next case. 37-year-old alcoholic, loose stools, no abdomen pain, highly dehydrated, tennisness associated with blood. So we are dealing with a case of acute gastritis, most probably a dysentery. So which is the simple investigation to decide whether the patient is need antibiotic treatment or not. So whether it is a stool culture, wet mouth, ram stain or hanging drop. So we need to check pus cells from the stool. If present, it could be a inflammatory, that is invasive one. If no pustules, it could be a enterotoxin mediated diarrhea. So if enterotoxin mediated diarrhea, these are all the commonest pathogen: Vibrio cholerae, enterotoxigenic E. coli, your Bacillus cereus, your Staph aureus, then all your Cryptosporidium and your all viruses, norovirus, rotavirus, all your viruses. If pustules present, that is inflammatory or invasive diarrhea. So all your Shigella, Salmonella, invasive E. coli, then your histolytica. So pustule present, we need to treat. No pustule